We also have a consultant and a pediatric endo, Anjana Hulse. Okay, yeah, you also have to participate. Come.
No, sir. There is enough place. I will tell you how. Some people will disappear. As a pediatric, this was endocrine training. No problem. Good afternoon, everyone. I think we are on post lunch. I don't know how alert we are. So we will have some cases now. I have two friends here. One is Dr. Sushma Rai and Dr. Anjana Hulse. I got to introduce both are pediatric endocrinologists. I got introduced to Sushma Rai through Anjana Hulse. So if I am associated with Sushma, it is because of Anjana. Thank you for introducing me to such a good human being. It's my pleasure to introduce her. She has done her MBBS from Mysore Medical College in 2004, and in 2011 she has done her fellowship with Dr. Raghupati. She is a pediatrician. So Raghupati sir is her mentor. So Sushma is very happy to present in front of her mentor, and we are all eager to learn from sir. And she was a faculty in St. John's for some time. Currently, she is in Rajarajeshwari Medical College as an assistant professor, and she also has her own clinic in Basveshwar Nagar, and she comes to Vikram to help us with the pediatric endocrinology. And I have been associated with her for last 1.5 years, and it has been a great experience. Thank you for being there with us. She will share some of her cases. She has lots of cases, and whenever we have any pediatric system, we should get in touch with madam. Thank you.
Thank you so much for that kind introduction, madam. And it's my pleasure also. I've been associated with madam. She's always been there trying to guide me and encourage me. And it's also my great pleasure to be presenting in front of my teacher and sir, Dr. Raghupati. And thanks to Professor Shrikantaya and everybody else who's given me this opportunity. So I'll just start off, I think. So this is the story of a 19-year-old girl who was referred for primary amenorrhea. So she's presently 19-year-old. So I'll start the story when she presented about 2.5 years back when she was 16.5 years. So she had presented with history of no menstruation for the past 1.5 years because there was some history to suggest there was some spotting at about 15 years. And when we inquired, it looked like there was some late onset of pubertal changes in this child, which the mother thought had begun at about 13 to 14 years. And then it had progressed, and there was a history to suggest the growth spurt at about 14 to 15 years of age. Otherwise, no history to suggest any chronic illness. Mother's menarche was at 13 years of age. And in the family, there was some history of late onset of menarche, with the maternal grandmother having menarche at 18 years of age. And in the other significant history, there was history of weight gain in this girl from the past 2 years. But before she came to us, in the past 6 months, she had lost about 8 kgs. There was also history to suggest abnormal facial hair, which had started at about 13 to 14 years of age. And she was presently, or even before that, she was undergoing laser treatment, and she was well controlled with that, and that was not of a major concern as of now. There was significant family history of diabetes mellitus, no history to suggest any infertility or polycystic ovarian syndrome in the family. She did have a little bit of a bad lifestyle in the sense that she would have junk food quite frequent earlier, but now it had come down to occasional, and some amount of physical activity of about 15 to 20 minutes, about 2 to 3 days per week. So on examination, weight was 70 kgs, which was between the 90th to 97th centile, and height of 170 centimeters corresponding to the 97th centile, and definitely tall for her, sorry, so definitely tall for her mid-parental height, so she was more than the target height. And the BMI, of course, 24.22, and which was falling in the overweight range. There was some facial hirsutism, but with the laser therapy going on, it was not really too significant and difficult to stage it. And her Tanner stage was good, so good secondary sexual characteristics, so she had attained Tanner stage 5. And the local examination of the external genitalia, there was nothing to suggest any vaginal problem or outlet obstruction. Systemic examination was normal. So coming to laboratories, which she had already come with. So just before coming, I think about 6 months back, there was some list of investigations which were done. So the imaging showed a uterus with the size of about 4 into 2 into 1 centimeter with a thin endometrium. This is at 16 and a half years of age. And ovaries were good volume, so 4 into 1.7, and with the suspect PCOS changes as recorded by the radiologist. Her karyotype revealed normal 46XX karyotype, and she was euthyroid. The other lab assays which was done, a basal estradiol level which showed a good pubertal, which was in the good pubertal range of 125 picogram per ml, and LH high 30 milli international units per ml, FSH also on the higher range of normal. Prolactin and prolactin was appropriate. The other androgens, the DHEAS was appropriate, but the free testosterone and androstenedione levels were high for the normal lab normogram. And she had a basal 17 hydroxyprogesterone also, which was done, which was about 2.2 nanogram per ml, maybe on the high normal range. So with this findings, we have a child with primary amenorrhea, and definitely she's overweight. So we were considering, is it just metabolic syndrome with the picture of polycystic ovarian syndrome? And of course, because of the significant history of hirsutism, we also wanted to rule out a non-classical congenital adrenal hyperplasia. So this is the lab workup which was done now. So for the metabolic syndrome, she was screened for the glycemic profile and the lipid profile. So the glycemic profile showed fasting insulin, which was a little high, and the HOMA-IR being high. And others, the lipid profile again showed a dyslipidemia of high LDL and low HDL. The other hormones which were repeated were the, testosterone level, which was again a little above the normal range for the Tanner stage, and free testosterone levels were also quite high. I have not put down the values because the units are different in different labs, but it was definitely high for the normogram. And because there was a suspicion of non-classical CAH, even we went ahead with the synactin stimulated test, and the maximum 17 hydroxyprogesterone after ACTH stimulation was 225 nanogram per deciliter, which kind of ruled out the non-classical CAH with an appropriate cortisol response. And at this point, because we had ruled out the non-classical CAH and our one differential diagnosis was of metabolic syndrome, she was suggested lifestyle changes and was commenced on metformin. So in this slide, I will just go through her progress. So this is the labs with which she had come by, and we have already gone through it. And for the next 2 years, we have some lab values. So the metabolic profile of the glycemic profile, the impaired high fasting insulin, periodically with lifestyle change and metformin, it has presently come down, and even the dyslipidemia is showing an improvement. The estradiol levels, as we can see, over a period of 3 to 4 years, it's been good. So the latest one is in 2018, just about 4-5 months back. And the LH, as we can see, is periodically between the range of 30 to 40. The last one is the 2018 one. And FSH also a similar range of a high normal range of stimulated FSH. And the androgen levels, which were high in the beginning, has slowly shown improvement, and it's now in the normal range, and similar to this. And what we can see is the uterus, which we saw in 2015, periodically over a period of 2 years, actually hasn't shown much growth, and it's always reported as a small uterus or an infantile uterus. And also the endometrial thickness is always very, very thin. So once it was reported as 3, but later it's always been thin endometrium and maybe less than 2 or just minimal. And always we have seen that the ovarian volume and ovarian size is good. So ranging sometimes even into the possibility of a polycystic ovary. So now after the first line, when we started her on lifestyle changes, the next time, of course, when she came in and not much was happening, I put her on oral contraceptive pills, but the maximum she had after about 6 months was just a spotting. And then, of course, because with this picture where the uterus is just not growing and good ovarian volume, and we have kind of kept in control her PCOS, we asked for MRI just to make sure there were no structural problems in the Mullerian duct. So the MRI pelvis showed again a small uterus and very thin endometrium, normal ovaries, and no other structural anomalies. So summarizing, this is a 19-year-old girl now with primary amenorrhea, appropriate secondary sexual characteristics for the present, and with some history of hirsutism and overweight. And in the labs, we had noticed insulin resistance and some dyslipidemia, and definitely good ovarian function, which continues to date, and a small uterus. So the challenges here for me was, what is the final diagnosis? What is the cause for her amenorrhea? So is it something, something to do with selective resistance of uterus to estrogen? And but we still have evidence. We have the criteria fulfilling for polycystic ovarian syndrome. So is it that with something else? And of course, what do we do for her further management? So does it require any kind of histological examination, or though she's producing so much of good estrogen, is there a role for exogenous estrogen therapy? So when I was just reviewing this, I just thought that selective resistance to estrogen is very, very rare. So when I was just looking up, I found a case report which was reported quite recently, where they found delayed puberty and estrogen resistance in a woman with estrogen receptor alpha variant. So just summarizing the case, so they have kind of labeled it as estrogen insensitivity syndrome, which is kind of similar to androgen insensitivity syndrome, which is very well characterized because of androgen resistance because of the mutation in the androgen receptor. So in this condition, they documented a mutation in the gene encoding the estrogen receptor alpha, ESR1, and this was actually described earlier only in one male, and this they have reported in an 18-year-old woman who presented without any breast development and amenorrhea. And the other findings which they have documented are markedly elevated serum levels of estrogen and bilateral multicystic ovaries. And of course, the mutation was detected by the gene studies. So when we look at the case report, it's kind of suggests that we cannot say that complete estrogen insensitivity is the only phenotype. There may be a spectrum where you could also have that some residual estrogen sensitivity could be present in some tissues, like probably in our patient where the breast and other things were fine, but only it was the uterus which was not responding. And because the prevalence of these mutations is unknown, because it's very, very rare, and probably just about 5 cases have been reported. And so it's really a question mark whether milder ESR1 mutations could still exist and probably cause an incomplete estrogen deficient state, so which is similar to the partial androgen insensitivity syndrome. So, thank you. So,
thanks, Sushma, for nice presentation. And incidentally, Sushma won the best case presentation in an international conference at Asia Pacific. And as usual, you have presented quite well. And this child, as you were saying, the breast development and all was normal. Secondary sexual characteristics advanced quite well. but it was just the hypoplastic uterus.
Yes.
So I think partial uh, estrogen sensitivity, just like partial estrogen sensitivity. I think that's the answer in this question. Anybody wants to ask any doubts? Which one? No, I don't
It's
think
a,
so.
it's a very rare entity. So in fact, even when I was looking up for this child only, I just found it. But there are about 5 cases reported. And when yes, not partial, the estrogen insensitivity. But what they're speculating is just like how we have partial androgen insensitivity, we could have partial estrogen insensitivity because estrogen is so. Yes, yes.
No, estrogen resistance, we also had a case. I was also looking up. These reports don't mention very clearly uterine structure and all that. They only say it was hypoplastic or small, but they don't speculate about only uterus being affected. You know? So probably that is the reason here.
So the estrogen is working on the breast.
Yes, sir.
And you expected, what is the usual FSH levels in these patients are reported?
I would have expected more.
Yes, sir. So even in this case report, it's quite high. So both the LH and FSH was quite high. But
Predominantly LH was high.
yes, sir.
Yeah.
Mine predominantly LH was high, but even the FSH, if you look at the normal range up to 12, 13, so she's touching that, and now recently it's come up to 14.
I was also wondering whether the grandmother had the same condition.
But she's overcome it and she's had her menarche and.
But very late.
Yes, sir, 18 years.
Very late, yeah.
Estrogen works in some tissues, does not work.
Yes.
Like the cerebral receptor modulator.
Yes, sir. Yes, sir. So that's
As it did in some of the males also. So probably, yeah. That is.
The genetic characterization you can't get.
I know.
What about the treatment?
So that I'm looking forward to some inputs from the yes, sir.
No, instead of OCP, now we have shifted to estradiol valerate. That is without much complication and so on. And so we don't use OCP anymore.
Yes.
Okay. And here estrogen is required, but I don't know whether it's going to improve bone metabolism and all that if there is a resistance, you know. And that's what we are worried about in amenorrheic and those who do not produce estrogen properly. That's what we are worried about. But in their case, it will work. If it is resistance here, I'm not sure whether it's going to work.
I think I had, sir. I'm sorry, I've not put it up. I think it was okay, but I can't remember. Yes, yes, I can't remember that. It was.
I don't think
Yeah,
so.
that's also a comment which I'm looking from the audience because I always feel we shouldn't miss a common diagnosis instead of putting her to a very, very rare diagnosis. So is it some rare presentation? No, no, she's off. She just got it for a transient period of about 6 months. After her levels improve, she's off it and she's doing quite well metabolically in terms of her weight and metabolic profile. But only this doesn't seem to be getting better. Yes, sir.
So treatment-wise, you give her estradiol, give her the endometrium,
Yeah,
then give cyclic progesterone.
probably.
And whether they won't be like
They will not if it is, I don't know, complete androgen, estrogen insensitivity. But in her, I think it's not really complete. So maybe.
maybe you do 17 OHP. Somebody who comes like.
Because of the hirsutism, I think we need to think of that. Yeah, in older individuals, especially if cystic acne or something like that, we definitely have to do. I don't think so. But the 17 OHP going from 2 to 200.
No, sir, 2.2 nanogram per ml, and this is 220 nanogram per deciliter. So almost.
Oh, okay. That was a little confusing.
Yeah, units are different.
Yeah.
Okay.
Yeah.
Correct.
Yeah. So that's okay.
Yes.
Yeah, that's right. You got another case or?
Yes. This is a story of two siblings. So I'll start with the girl who presented first. So she's a 17-year-old girl who got referred for primary amenorrhea, and she was, and the parents had noticed that the pubertal onset had started at about 15 years of age, and the mother thought it was a gradual progression to the present state. And in the perinatal period, she had a low birth weight, but otherwise no other significant perinatal events requiring any intensive care admission. However, the development was delayed, and presently she had managed to reach the 10th standard, though she was not very good at her academics, and she was able to manage her day-to-day activities. So in the past, this child was diagnosed to have myoclonic epilepsy at about 9 years of age, and she was on anti-epileptic drugs, which she presently continues to, and is presently well controlled on it. So during that course, as investigation for the epilepsy, MRI of the brain was done, which had otherwise ruled out any other structural malformation, but was reported to have a pituitary size in the lower range of normal. And she was also on thyroxine supplementation for hypothyroidism for the past 5 years. And this girl's mother had attained menarche at 15 years, and by history, the sense of smell seemed fine, and there was no history to suggest any polyuria. On examination, she was well child with normal vitals and weight being between the 75th and 97th centile, height between the 10th and 25th centile, corresponding to the mid-parental height, BMI in the overweight category, and no dysmorphism or any neurocutaneous marker. Again, Tanner staging was Tanner stage 2 in a 17-year-old girl, and systemic examination was normal. So we have a child with delayed puberty, epilepsy, well controlled on treatment, with some intellectual deficit and hypothyroidism on treatment. So when we look at all this, probably we are looking at a child with hypogonadotropic hypogonadism in the setting of probably a evolving hypopituitarism. So this child's screening lab test for pubertal onset was all appropriate systemic labs, and she was euthyroid, prolactin, and other hormones of the anterior pituitary were normal. The bone age at 17 years was about 13 years, and the ultrasound again showed a hypoplastic uterus and a small ovaries. And basal hormonal level, the estradiol level showed in the prepubertal range, and LH and FSH were really low. So 0.02 of LH and FSH 0.48 milli international units per ml.
The thyroid function tests were on treatment.
Yes, sir. Yes. On treatment, she was euthyroid, 25 microgram per day. So because of the low basal levels of hormone and suspicion of hypogonadotropic hypogonadism, we went ahead with the GnRH analog test, which we used the leuprolide. So the stimulated level of LH, as we can see from basal of 0.02, maximally it has gone up to 0.42. And FSH of a basal level of 0.48 has gone up to a maximum of 4. And the estradiol, which was low to begin with, basal, even after stimulation after 24 hours, was still quite low. So now I think we have kind of proven that this child has central hypogonadism, probably hypogonadotropic hypogonadism with some congenital hypopituitarism. So in the background of this, it probably looks at this.
Don't have any previous reports.
We don't have the previous reports. And considering that she was on a low dose 25 microgram and all the other comorbidities of a central problem, so probably we're looking at a central hypogonadism. So management, the family was counseled and commenced on estrogen replacement. Thyroxine was advised to be continued. Of course, she needs periodical growth and pubertal assessment. and with careful escalation of estrogen dose, and later we need to add progesterone once the estrogenization occurs. We will need annual screening for other pituitary hormones and uterus imaging and bone age as indicated. And during the next follow-up, the mother brought her 14-year-old brother, who also was brought in with the concern of delayed puberty. This boy otherwise just had some history to suggest weight gain, which was again attributed to a lazy lifestyle. Others, he was always well in the past. The parents were non-consanguineous, and father's puberty was attained at an appropriate age, and the sense of smell even in the boy seemed fine. On examination, the brother was well, no dysmorphism, vitals normal, weight again more than the 97th centile, height on the 97th centile. So the BMI suggesting that he's in the obese category. And this child had Tanner staging of stage 2. His testicular volume was just about 4 ml bilaterally, and the stretch penile length was 5 centimeters, pubic hair of stage 2, and some axillary hair just appearing. And systemic examination was normal. So at this stage, a 14-year-old boy presenting with Tanner stage 2. So I just thought we have to give him some time. So I saw him again after 7 months, and during this period he had gained some weight. Height was the same, and the Tanner stage remains static at stage 2, and that's the similar features. And of course, we have the significant history of the sister having the possible hypogonadotropic hypogonadism. So now we went ahead and investigated this child. So his screening tests were normal. The other anterior pituitary hormones were also normal. And in view of his obesity, we went ahead with his glycemic and lipid profile, which was kind of appropriate. And the bone age was 15 years now, at about 14 and a half years of chronological age. And the testosterone level was 12.9 nanogram per deciliter, so not too great. And again, a LH FSH, which is quite low. So because of the basal levels being low, we went ahead with the GnRH test. And as we can see, the LH again, which was quite low, has improved maximally to 0.75. And FSH also 0.7 has improved maximally to 3.37. And the testosterone stimulated hasn't shown much of a jump. So here, of course, in the background of the sister, I think the first diagnosis looks like isolated hypogonadotropic hypogonadism. I know many in the audience will still jump and want to make sure that we're not missing constitutional delay in growth and puberty. So that would be one differential diagnosis, but because of the family history and the way the sister presented, and so I think this was the foremost diagnosis. So my main idea of presenting this case was, and then of course because we thought of hypogonadotropic hypogonadism, I thought this child also needs to have an imaging. So the MRI pituitary which was done, the size was reported as normal, but they found ill-defined, non-enhancing 5 into 5 into 4 millimeter lesion in the right lateral lobe of the anterior pituitary, and it was reported as probably suggestive of microadenoma. And as a result of this, we got his detailed ophthalmological examination done, so which was suggested to be normal. And however, he's yet to come back after a neurology review, which I got to know was probably reported as it could be an incidental finding, and however, of course, needs to be on follow-up for the lesion in the pituitary. So the main points for discussion for me in this case was about trying to look up genes responsible for hypogonadotropic hypogonadism, where a sister and brother have presented in the same family, and to look at any genotype and phenotype correlation, because there are many number of genes which are reported. So if we have some genotype phenotype correlation, so is there possibility of narrowing down these genetic tests, and probably some implication for the future, because these are the questions which the parents want to know. And since we have a boy who's recently and quite early diagnosed to have hypogonadotropic hypogonadism, can we have a change in the management of pubertal induction using gonadotropins, and to look at the cost versus benefit margin in these children. So the genes in hypogonadotropic hypogonadism, there are quite a few, and we know that few of them have been reported for a long time. But recently, many more genes have been added to the spectrum, and we know that it's a spectrum of the constitutional delay, and the hypogonadotropic hypogonadism is a spectrum which starts from one end and ends in the other end. So there are a lot of interlinking genes which can be responsible for these, and some of them may be even present in the normal population. And so coming to the treatment of the hypogonadotropic hypogonadism in boys, and looking at treatment in terms of pubertal induction. So the choices are for replacement therapy. So testosterone therapy for pubertal induction was always conventionally used. Now there's a lot of literature to give us some way ahead to use the gonadotropins, but there are many different regimens which have been used using FSH alone or with HCG, or HCG alone and both of them in combination. And also it has been reported that these results will differ depending on the etiology of the hypogonadotropic hypogonadism. So congenital versus acquired causes. And so what is an effective regimen? I think an effective regimen should be able to achieve normal adult height, should have adequate spermatogenesis resulting in good fertility, and in addition to, of course, developing physiological secondary sexual characteristics. When I did a review, I think I found one of the protocols which was used by the Japanese Paediatric Endocrinology team, and what they have said is there are some indications in which you can use the gonadotropin based pubertal induction. So in any boys who have very small testicular volume and may have some, and you assume they will have poor spermatogenesis because of their genetic etiology like Kalman syndrome or isolated gonadotropin deficiency. So there are different regimens, but one of the regimen which they have suggested is a pre-treatment, because I'm looking at congenital hypogonadotropic hypogonadism. So pre-treatment with the recombinant FSH for 2 months daily, and then the FSH can be used in combination with HCG. And it has to be started early. So the idea is to start it at an appropriate age of which physiological puberty sets in. So start it early and increase it very gradually every 6 months till we reach the adult dose of HCG of 3000 IU and FSH of 75 IU. Thank you. And
the first case,
yes,
MRI was there?
Yes, sir. The MRI was actually, she had come in with that MRI which was done at 9 years, which had not shown anything major. Yeah, only the pituitary was reported as in the smaller size of normal.
Cortisol levels in the
First case was done, sir, it was normal.
basal or simple?
Basal. Growth hormone, she had already attained her growth, so there was no role to do it. Yeah.
Very tall.
Yeah, the first, yeah. Yeah.
Autoimmune thyroid disease.
Oh, is it done? I missed that. Okay.
The grandfather comes to me for diabetes.
Okay.
This boy was 176 centimeters, which is quite good. Any comments from your side? No? I just wanted to say about the management. We have had very poor results with FSH and LH treatment, and perhaps we started late because that's the age when they come, and perhaps we should have picked them up earlier. But I've tried more than 6 to 10 cases. None of them were successful, and it's very expensive, and it's quite a long treatment. And at least 15 weeks, 15 months, sorry.
If you stop again,
Yes.
Oh, it is. 15 months you have to continue. Initially you start with HCG, and then you start off with the, and the 15 months, 15 months.
go back to
What else to do? Yeah.
and if you give in adult fetus spermatogenesis induction, HCG started only when they desire fertility. Otherwise, the treatment is.
Yes, sir. That was what was done. So I am looking at any inputs.
See, the moment you stop gonadotropin, the test is going to atrophy, count will.
And we start uh, the testosterone depot preparation straight away. And this is much better than the monthly regime. And the children or the individuals feel much better instead of going through ups and downs of depression and, feeling of well-being. And I would straight away start on 3 monthly depot preparation.
Yes, reporting of pulsatile GnRH, like an insulin pump. Reported.
Yeah, no, there is, and I share your concerns about that, and your concerns. I mean, I think that this is a very new field, and I think in a few years we're going to have a much clearer view on how to actually do this. And at this point in time, the whole question about whether or not you should use these medications or not is very controversial. The people who use it and advocate it, the point they make is that the child gets good testicular size, but as you say, the moment you stop it, the testes shrink back down again. And my take on it is the size of the testis is not important. What the families really want is sperm production. That's the thing that they're really concerned about. And I'm not convinced that there's any evidence that there's better sperm production if you start early or if you start later. Have you seen anything like that where they've compared those? I haven't seen anything like that. You know, so really the question about what we should do there is really not known. I think the point about the thyroid in that first girl is very interesting. I mean, it's really important to make sure that the thyroid function is normal because, of course, that can stop pubertal development. And rather than just looking at TSH in this girl, I'd also look at TSH, FSH, which I should done. Free T4. Yeah. And so, because of course with the pituitary cause, then you can see a TSH which actually looks normal or even sometimes a little bit on the high side. But the big trick is that T4 is low and you won't get anywhere unless you treat that, the hypothyroidism. The dose of thyroxine is very low, which I find is very interesting. So it's whether or not she's got a very mild form of what a mother's got with whether they're relatively low. And the whole question about whether or not this could be panhypopituitarism or not is very interesting. And when I think about this, is it okay if I use the board? You guys probably already know this, so I apologise for going through it. But I think about this in very, very simple terms. And what I'm going to say is wrong, but it works in practice. And the way I see it is you get your stem cell starting there, and then it goes through a process. So your primitive stem cell goes along and at about halfway along its development, you get diversion, and one is to ACTH producing cells. So you corticotrophs, the other ones to your gonadotrophs, so LH, LHFSH producing. Right. And down this end, you've got a verification where you've got TSH, growth hormone, and prolactin. And so a very easy screening test is if your testosterone's normal, if you panhypopituitarism, if the growth hormone is normal and the prolactin's normal, then it's highly likely that the majority of the rest of it's going to be normal, because if that's abnormal, then you're talking about insufficiency. If this is abnormal, you're talking about an isolate. The thing, of course, the trick with this is you've got the placode which forms in the nose, then migrates through to the pituitary. You're all aware of that. So you've got nasal placode, which is where the LHRH producing cells form. Then they And so again, if that's isolated, then it's usually in that cluster of genes that you were talking about before. And so with this, I mean, the highest probability with that girl is that she is a Kalman's syndrome without the anosmia, the intellectual impairment and things like that. That's a very common thing that you see with the kids with Kalman's, and particularly you can see varying grades of intellectual impairment. You can see the straight intellectual impairment, or you can see milder forms in the forms of mild epilepsies, or you can see it's very common for them to have a kind of what we call attention deficit hyperactivity disorder. It's a very common diagnosis that they get. They have a couple of other genetic abnormalities that you'll see, particularly the renal system, where they can have congenital kidney abnormalities. So when you're thinking about it, so it's a very good question about what's the growth hormone. The trouble with growth hormone measurement, of course, is if you do a random test, it's useless. And if you've got someone and you do IGF-1, then that's pretty difficult too, because they just haven't eaten much the day before, or they're sick at all, or anything like that, or they're using the wrong reference range for their maturity, then you'll get a level which actually looks low when in actual fact it's just when you actually did it, the timing of it, things like that. So yes, I agree with it. I think everything we've said is exactly right. It's we struggle with whether or not to use gonadotropin stimulation in these children, and we really don't know the answer, is my take on it. No. So the development of the cells go along, and so you've got things like HESX1, which is the Morzier syndrome, and those children will have complete absence of the pituitary. They won't have ACTH. They'll be hypogonadal. They'll have no TSH. If you get an interruption there, which is things like CROP1, then you'll get TSH growth hormone prolactin affected, but ACTH, LH, FSH impact. And so what you're talking about is where the cells are going through in their neuronal development, from the cellular development as they go through from stem cell to mature children. That means, yeah, and you can assume that's right. We've heard that a prolactin's right. There's a high likelihood that this is, as you say, the autoimmune. It's highly likely that this is going to be intact, and what you're talking about is an isolated, only this, which means it's in gene pool that you're talking about. So, very clear concept.
We had lined up a lot of cases, but I'm making sure that we have one more reproductive English, and you have seen the lady once, and then we'll close. Okay, same thing. One more, fast. Continue the same.
Next ಮಾಡ್ತೀನಿ. This is a case of 46XY gonadal dysgenesis. A 19-year-old female came to us. She was referred by actually a gynecologist for query androgen insensitivity syndrome. She had a history of bleeding PV that was very scanty, only spotting, that 3 months back, and no periods after that. And these investigations were done by the gynecologist only. Ultrasound abdomen showed no uterus and ovaries, and FSH, LH were normal. E2 was low, and prolactin was normal. On examination, there was no axillary hairs, no pubic hair, and breast was Tanner stage 2. And on pervaginal examination, there was a blind pouch of vagina. And PR showed uterus not left felt. And they had done karyotyping, and the report was male karyotype 46XY, inversion 9, and the presence of Y chromosome noted along with inversion of chromosome 9. And the nuclear genotypic sex is differing from paired phenotypic sex. The primary assessment, our assessment was primary amenorrhea, 46XY gonadal dysgenesis versus testicular feminization syndrome, that is complete androgen insensitivity, and disorders of sexual differentiation. And on physical examination, she was tall, thin-built with marcanoid features, long, slender fingers, high arched palate, and thumb sign was positive. And there was no axillary hair, no pubic hair, and breast was Tanner stage 2. And actually, we referred this case to Dr. Raghupati sir, and they did some investigations there. That is fish fluorescence in situ hybridization that shows positive for SRY gene. And a repeat ultrasound abdomen showed uh, that was done by us showed bilateral testis seen in the inguinal canal. And echo was there was trivial MR, EF was 65%. And we repeated the karyotype, and again the report came as the same report about it was earlier. Male karyotype 46XY, inversion 9. Pericentric inversion 9 does not have any consequences. And this BMD showed severe osteoporosis. That was left femur was -3, right femur, left femur -2.7, and spine was -3.3. And these were the investigations done. And throughout the FSH and LH was normal, and except in the last this thing it was 120, and E2 was low, and incidentally testosterone was normal and low normal. In the last after gonadectomy, it was after surgery. After surgery. And this is the family history. She had one younger sister, 17-year-old. She was a case of PCO with delayed menarche at the age of 17 years. And her karyotype showed female XX with chromosomal aberration of inversion of chromosome 9, which is a variant and of no consequence. And even the parents, her parents have been advised karyotyping, but they've not done. Mother attained menarche at the age of 17 years. So final assessment was complete androgen resistant was ruled out, and 46XY he was 46XY phenotypic female, primary amenorrhea, and there was absent Mullerian structures. She was a case of hypergonadotrophic hypogonadism, osteoporosis due to hypogonadism. She underwent bilateral gonadectomy in March 2018. HP report was cryptorchidism, right and left testis. And patient was comfortable in the role of female gender, and so she was started with the estrogen replacement for breast development and osteoporosis prevention and also cardiac benefit. She was started with estradiol 1 milligram from 1st to 21st day of every month. So the discussion here is what is the precise diagnosis in this 46XY gonadal dysgenesis case?
First girl came was because the petrol levels were of the low range and then pulled out. So 45, 46. The other sister didn't come. They just told us she also has family amenorrhea. So we got her in thinking that she might have, but she turned out to take PCOS. And I don't remember this case.
Genitalia is female side. He had a well-developed female genitalia, but the vaginal, she had a small vaginal pouch. Testosterone levels.
Complete androgen insensitivity syndrome seems to be the diagnosis here because the karyotype is 46XY and SRY is also seen. Gonads are uh, proved by histopathology and no Mullerian structures. The only odd feature is that the testosterone is not raised. That's the only odd feature, and the LH, FSH were also high. Testosterone is very low, so there is no conversion to estradiol. Yeah. I know, but it is a high testosterone which peripherally gets converted to estrogen, and because there is no interaction with the testosterone, estrogen sensitivity is very high. So the breast development proceeds normally as in a girl. But here there is no testosterone level, and that's a little bit of confusion.
Can we make insensitivity lower, subnormal testosterone?
So my understanding of the testosterone was that it was 12 on one and 18 on the other. What were so what's your reference range for testosterone?
Reference ranges. 14 to 76.
Adult female.
Yes, yes.
Adult female.
Because I'm sorry about the confusion, but because when I was looking at that, then I was thinking in Australia that would actually be a really good solid adult range for males. But obviously you're using nanograms, where we use nanomoles. So yes, the levels are relatively low, and he's tall, which he's got a gynecoid appearance. So yes, I believe that this is just a variant on androgen insensitivity syndrome. I wouldn't be looking past that on the basis that that the testosterone has a normal, the testes have a normal histology. There is testosterone there, although there's not much. There's no androgenization. That the LH-FSH is normal, and so you may just be looking at him like his other siblings at the stage he is in his pubertal development. But I think it's androgen insensitivity.
Variant of androgen.
The LH and FSH aren't that high, and you wonder whether or not what we're talking about is his mother was late with, her mother was late with puberty, her sister's late with puberty. Are you actually seeing that there's an element of constitutional growth?
I don't know whether it's disuse atrophy. Because it's not being producing enough testosterone, you know. I have no explanation.
The only other thing I'd be interested in your comments on would be long-term hormone replacement, because what we do with our children is we put them onto a medication where they have cycles where they end up on good normal physiological doses of estrogen for 21 days, but then a continued low dose of estrogen in between those, because what we think happens is in women who have when they're having their periods, they are still producing some testosterone. And we think that the thoughts have been that that testosterone is important to maintain bone mass so that they don't get osteoporosis in the long term. So do you guys do that as well, or?
This patient wanted to be a female, wanted to be raised as a female, so you are giving estrogen. Estradiol, yes, estradiol. So same.
So absolutely. I mean, the big issue here is that if it's either way, the testes are internal and your risk of cancer is high. And if it's truly mixed gonadal dysgenesis, then your risk of cancer is extremely high.
Good. No. See, it's also new to me. We reviewed there's a whole review article of more than 80, 90 syndromes which come within this 46XY. And unless you do some somatic abnormalities, this girl had little morphonoid features. So we don't know the answer. But 46XY convergence has been described with exactly the same features. So we don't know how to separate. Abdominal histology.
Abnormal histology on the testicle. Yeah.
And histology is orchid test. I have not gone really. Okay. Now, since some of the faculty are leaving, we'll do a small honors. Come. Bruce. Okay. We request Raghupati to honor Dr. Bruce. Small fond memories. We request Shuchy to honor Angie. Shuchy. Come there. Picture, please. Okay. One second. Got the picture. Please. Siddharth, action. One second. Kamala is extremely close friend of Raghupati. She discusses. One second. Lakshmi Reddy to Sushma Roy. Come. Come. Lakshmi. Just one second. Okay, now Shuchy, Angie to honor Shuchy. I am here always. Come. Just one second. Come. No, you will come. Please, student as an announcement. Come.
I just want to say that sir got international destination award.
This one. Now, we have just one honor for Anjana. Wait. and Dr. Raghupati has to go back to his clinic. This will be immediately followed by, when we give too much diabetes lecture, audience get bored. Use endocrine to keep the cerebral cortex. And after this, he will give his guest lecture on Addison's disease and adrenal insufficiency. Then rest of it will continue the pediatric diabetes part, the remaining lectures. Some which we missed, we're going to, as I told you, next Tuesday, there is a workshop by Mr. Adam Lamendola. He's a senior diabetes educator, pump trainer. So it will be more practical, and we are inviting patients to experience sharing, etc. Kavita. So, Bruce, to the young pediatric endocrinologist. Now we shall continue. Thanks a lot. Now next is adrenal insufficiency by, as you know, there are a lot of young postgraduates make the best. Put the garlic.
Yeah.
So thank you everyone who stayed around for this part of it. What I'm in this talk, you've probably noticed in my other talks that I've had pictures. In this talk, I'm actually going to do honour to my city. I've had the honour to be shown around Bangalore and surrounds over the last 2 days, and to see what a beautiful country it is and what a beautiful city. And so now I'm going to try and show you that Newcastle is a beautiful place too. And of course, if any of you come to Newcastle, you're more than welcome to come and stay with me when you come. So I'm going to talk about adrenal glucocorticoid stress and Addison's disease. And so before I got right into diabetes research, my PhD was in the molecular biology and regulation of the HPA. And so a lot of what I'm going to say is in the molecular biology stratosphere, but not really in some of the clinical stuff. But I hope it gives you some insight. I've tried to make it as clinical as possible. So I'm going to talk about regulation of the HPA, hypothalamic pituitary adrenal axis, central adrenal insufficiency, adrenal testing, adrenal insufficiency, steroid replacement, and adrenal crisis. So when you think about stress, it's a mistake to think about a single form of stress. What you see with the hypothalamus, if you look at the hypothalamus, there's some cells and there's a whole pile of neurons, of axons coming in, talking to the cells in the hypothalamus. And so it's, if you like, a converging urgent point, which interprets the data it's given and then coordinates a response. And so you'll see stress, which is literally in the mind. It's just a stress thing. And you'll see other physical kind of stressors which can affect us. And the hypothalamus coordinates and regulates both of those, all of those inputs to come up with what is a logical interpretation and response. So when you look at the I'm sure you're all familiar with this, but I'm going to bore you with it anyway. The hypothalamus produces CRH, which then goes to the pituitary, which produces ACTH, which then goes to the adrenals and produces cortisol. And the cortisol has a negative feedback on the hypothalamus and CRH production, and negative feedback on the pituitary and ACTH production. Now, what does this mean in reality? So if you imagine you've got a person and they have a severe stressor, so here they are, something's happened, the squirrels are jumping on them and they're bitten by the raccoons and they're losing blood, they will get a sudden rise in cortisol in the stress response. So they'll get, if you look at it at the molecular level of what's happening in the hypothalamus and what's happening in the pituitary, there's this exponential increase in production of CRH and ACTH. It's literally exponential, very, very, very rapid and very, very high. And so what you see then is you get this surge of cortisol with the surge of ACTH that occurs. But then you've got negative feedback. And it wouldn't make any sense if the negative feedback was such that you turned off the cortisol production completely. So what you actually get is a drop down and then a running along and a smoothing where it's incorporating the negative feedback, the signals that are coming in, to again make you a coordinated response. This research here was actually done in India by some fantastic people in an intensive care unit, where they showed that if your cortisol level was over, I think it's 900 nanomoles per litre, then your mortality exponentially increased. So it's actually very positive and a normal thing in someone like in intensive care to see a cortisol around 600 or what have you. There's other inputs which affect it. So there were experiments in rats where they actually did adrenalectomies and they gave the rats salty, sugary water and could suppress the ACTH down to 0. So when people are in ICUs, they're also on intravenous fluids and electrolytes and glucose. And so that can actually suppress down this response as well. In a normal response, in a normal person, what you see is that there's a circadian rhythm with the low point at about midnight and then a progression up, drop down through the day. And so, and what you're seeing here is that there's really quite large differences at any particular point in time. And from what I've already said, you can interpret that it's very common to have low levels at any one time. So it's possible that on any one day, if you do a random cortisol level, you can get something that looks low, but it isn't low because you've just measured it on that day where the coordinated response has brought you up with that. So a single random cortisol is actually a pretty useless test. Neonates are a particular bugbear of the paediatric endocrinologist in the fact that they haven't got a fully established circadian rhythm. And if you get half my car is paid for by neonatal intensive care referring children with cortisols of 60, because in children at this age, a cortisol of 60 is actually normal. And so we see that all the time. And the other thing is that, again, this was research from India, where they actually showed that in children who had hyperinsulinemia causing hypoglycemia, there wasn't necessarily any change in the cortisol level, even though the cortisol actually was normal. So causes of adrenal insufficiency, there's hypothalamic pituitary, which is non-pigmented, steroid withdrawal, which is non-pigmented, and there's a great big long list, but I'm going to keep my discussion to congenital adrenal hyperplasia, autoimmune adrenalitis, and infections. So in the hypothalamic pituitary dysfunction, you get loss of the ACTH, CRH and ACTH, depending on where exactly the lesion is. And what that means is that the adrenals aren't stimulated, there's low cortisol and no feedback. That, of course, is the hypothalamus, little triangular region there, pituitary gland there, and sort there. So, and it was great that we actually got to have this talk before, because what we can say from this is that if you've got central adrenal insufficiency, you've got two choices. Either you'll have a total pituitary malfunction, or you will have an isolated ACTH dysfunction. And the isolated ACTH dysfunction is extremely rare. But what you usually see with multiple pituitary deficiencies is you'll see those things are affected. And so the electrolyte abnormality, if you get one, is due to diabetes insipidus, because with central adrenal insufficiency, your renin-angiotensin system is intact. So you don't see that abnormality in central hypothyroidism. So if you're seeing a central electrolyte abnormality at all, it will be diabetes insipidus. And in neonate, you usually see that in the setting of really severe brain abnormality. In adrenal defects, so what you see is cortisol, aldosterone, and androgens affected. The other pituitary hormones are intact, and the abnormality you get with your electrolytes is low sodium, high potassium, high urea, and an acidosis. And when you see it, it's really quite obvious. So they're the kind of things that differentiate when you're looking between pituitary and adrenal defects. So I've already just talked about that. So here's a classic MRI from a child who's got multiple pituitary abnormalities. And what you're seeing here is an empty pituitary gland, empty semicircular, sorry, an ectopic posterior pituitary, and the rest of the brain is normal. So the other causes of central adrenal insufficiency are pituitary injury, so infection, head injury, shock, and tumours are the other big ones, so craniopharyngioma and astrocytoma. At our centre, we've seen about equal numbers of two. So they usually say that craniopharyngiomas are much more common, but we've seen probably equal numbers. This is a CT of a child, and that's his pilocytic astrocytoma sitting in a classic position. And he actually did well. The surgeons went out and pulled it out in one lot, which just about horrified myself as an oncologist, because we thought they were just going to go in and biopsy, and they went in and pulled it all out, and one thing but cured him. Steroid withdrawal. Usually, in Australia at least, this only occurs with oral steroids. The other forms of steroid you use rarely are at high enough. Rarely get high enough doses to take it. And they need to be on the steroids for a couple of weeks at a reasonable sort of decent dose for that to occur. Rare causes is topical steroids. And it's important to ask about what sort of steroids they're taking and how much they're using. I got a phone call the other day from a doctor who was concerned that the child had Cushing's syndrome because they'd been putting 1% hydrocortisone cream on their hand for the last 6 months, but they weren't a quarter of the way through the tube yet. So in reality, it was extremely unlikely that the child was just overfed. So asthma preventers are a really, really interesting one. There's a whole pile of literature. There's actually hundreds of articles where people have taken children and adults who are on inhaled steroids and shown about a 20% suppression on synactin tests. Now, the problem with this is that the 20% suppression on synactin tests roughly corresponds to the false positive rate that occurs with synactin tests. And if you look at all the children and adults in Australia who are on inhaled preventers for their asthma, we just don't see the adrenal crisis. So I'm really dubious that this is anything more than just talking. And we certainly don't see it as a clinical problem. We went through a whole audit by our hospital because everyone was concerned following these papers that everyone's going to get adrenal crisis. We never reported it. We continue not to be bothered by it. I think I've already shown this though. That's a day or two. The storm is still actually almost finished at that stage, but you can get an impression of how severe the storm was. One of the things about central adrenal insufficiency and testing and interpretation is that clinical acumen, the doctor's ability to actually identify whether or not there's adrenal insufficiency or not, is actually extremely poor, to the point where we think that, particularly for central, that if a doctor, if a really experienced paediatric endocrinologist diagnosed with central adrenal insufficiency without doing any tests, then there's pretty much a 99% chance they're wrong. So with central testing, what we always do is we do screening tests, so TSH, T4, prolactin, and UECs are a really good starting point. And if you look at this and think about this picture over here, if you do that, then that'll, with the multiple hormone deficiencies and with tumours and with injuries and things like that, this should actually cover most of it. They're normal, then it's highly likely that any particular issue. But if you're still concerned or if there's issues with this, then we do formal testing. And the formal testings we do, we repeat morning fasting cortisol, so we do them repeatedly day after day for about 4 to 5 days. We'll do a synactin test, a glucagon stimulation test, or insulin tolerance test. The problem with insulin tolerance tests is in children particularly who have multiple pituitary defects, then it's actually we think it's quite a risky procedure, so we rarely, if ever, do that. It's usually top 3. But the false positive with any of these tests is about 20-30%. And so what we do is we do one test, and if that's abnormal, we go on and do a second test. And if any test you do is normal, then we interpret it that the pituitary and the adrenal system is normal. And on the other day, it's just that we just picked up a day when they weren't going to respond to that. So with that, you can consider an MRI as a test, because if you've got an abnormal pituitary on MRI and you've got an abnormal synactin test, then hey, how many tests do you need, sort of thing. And if all the other tests are abnormal, like the TSH and all those other things are abnormal, and your synactin is normal, then again, that's probably fair call. The other thing is if you've got something like a trauma or tumour or infection or something like that, you've got to wait for long enough after the injury or the cause of the hypopituitarism before you'll see a change in the stimulation test. So if you do a synactin test in someone a couple of days after they've had pituitary surgery, it will always be normal, and you really have to wait weeks or so to give the adrenal chance to shrink down so that you can actually see the change. I always recommend high dose, regardless of whether I think it's central or peripheral. There was a big push at one stage for low dose, which is 1 microgram ACTH. Now, there's a real problem with 1 microgram ACTH, and that is that you have to dilute it to get it down to the 1 microgram. Synactin is extremely unstable when it's away from its preservatives, and it's very, very sensitive to light. So what that usually means is that unless you're really quick with the drawing up and injecting it, it's going to all be lost by the time you inject it. So there's a high false positive rate with it. The other thing was that there's been a recent BMJ meta-analysis of all the studies that were done on low dose and showed that there is no difference between high dose and low dose. And in fact, we actually went through a period where we actually did the same analysis ourselves before the BMJ came out. BMJ came out. We found the same thing. So a really low synactin test just add more workload and make it difficult to, and don't give you any better results than high dose synactin and increase, you'll have an increased risk of false positives. Adrenal defects, your CRH is up, your ACTH is up, and the ACTH is really easy to measure, of course. No one much measures CRH because it's just too difficult and too unstable, which is too small a protein molecule, whereas ACTH is fairly easy to measure. So that's elevated, cortisol is low, there's lots of feedback are up. So the most common cause of adrenal insufficiency is a 21-hydroxylase, which is 1 in 10,000. It's masculinizing in females, and it often causes salt wasting. And defects through there, of course, and so what you're seeing is that sex steroids pathways intact, but these pathways, the glucocorticoids and the mineralocorticoids, He's a female with ambiguous genitalia who has 21 hydroxylase deficiency, so you can see pituitary. He's a. This is what you see in a male who has a non-classic CAH, where they've had CAH that started to develop, but then they've gone in. One of the big issues with having CAH, a non-classic form where they have late presentation, is that they'll actually go and they'll start through puberty from the androgens, but then they'll go into true puberty. And so what you're seeing here is that you've got increased height, increased muscle, but the phallic growth, but the testicular growth is happening as well. And so this means that at the very least this person's into true precocious puberty, possibly induced by 21 hydroxylase or whatever it is. Oh, okay. That better. That should be better. Yeah. Okay. Sorry. Okay. So the other infectious cause. So if we just go back for a second, of course, if the defect is through this line here or anywhere this side of it, then instead of masculinization, you see feminization. So in those, you see males feminized with salt waste. One of the commonest causes in the world of adrenal insufficiency is tuberculosis, the destruction of the adrenals. I think it was they thought that about 3 of the 4 that Addison originally described were actually adrenal tuberculosis. HIV is interesting, and I think that there can be either a central or a adrenal impact on this. Waterhouse Friderichsen, we've all heard about. So autoimmune adrenalitis is actually relatively uncommon. 1 in 25,000 children. I've said 1 in 100, but the actual fact is about 1 in 300 children with type 1 diabetes have autoimmune, have Addison's disease. They produce 21 hydroxylase and antibodies. Now, the thing about the antibodies is if they're present, it doesn't necessarily mean that you've got adrenal insufficiency, but if you've got symptoms, if you've got adrenal insufficiency and you've got antibodies, then that's what the answer is. It's highly predictive if you've got symptoms, things like that. But you can have the antibodies and not have the disease, just like you can have the antibodies for diabetes and not have the diabetes. It's associated with other autoimmune disease. There's one called APEC1, which is caused by the AIR gene mutation. And what you see with that is mucocutaneous candidiasis, hypoparathyroidism are the 3 big ones. So adrenal, mucocutaneous candidiasis, hypoparathyroidism. But they also get a whole series of other autoimmune diseases as well, which you have to screen for when you find it. But at our centre, this is about 1 in 5 to 1 in 10 of our presentations of adrenal insufficiency have this gene. APEC2 is one that's most commonly associated with type 1 diabetes. It's also associated with Hashimoto's in a triad type situation. This is where the AIR gene interacts. So they think there's programming interference within the thymus, which alters cervical function. And this is the mucocutaneous candidiasis that you see. So you can see the nails, mouth are all affected. And you do actually see that with surprising frequency in these kids. That's fungal infection of the hair follicles and candidal infection in the mouth. So here's a patient that I saw once, a young man called Harry, and he presented with vomiting. He was unable to walk. He was sleepy. He had tachycardia, and he was poorly perfused. So he looked really unwell. He had a 6-month history, and this is one of the classic things with adrenal insufficiency, is that they can have a very long history of abnormality before they present. So he had 6 months of lethargy, weight loss, anorexia, intermittent abdo pain, vomiting, weakness, and postural hypertension. And this is him here, and you guys might not be so impressed by his skin colour, but for us, when you compare him to his mum, he really is very, very, very tan. And what you're seeing is that there's no, usually in people like me, you see, in Australia, you'll see the tan line where they'll be brown there and white there, and he's just brown all over. There's no discrimination one by the other. So there again, there's no real tan line. And his flexor part and extensor parts of his limbs, there's increased pigmentation. These are his electrolytes when he was diagnosed, so you can see low sodium, high potassium. Interestingly, his bicarb wasn't that low, but usually you'd see it much, much lower than that. And his glucose was normal, which is a little bit surprising given how sick he was. And cortisol low, ACTH high, plasma renin high, and very long chain fatty acids were normal. So what you're seeing here is, do you need a stimulation test for this guy? No. How many things do you need to say this is adrenal insufficiency? So you've got the test, you've got the clinical presentation, you've got the abnormal electrolytes, you've got a couple of other markers, and that's enough. You don't need a whole pile of the very long chain fatty acids are very important in males because a high percentage of males who have adrenal insufficiency will have defects, and that's adrenoleukodystrophy. So what's the oil called? Lorenzo's oil. Yes, so the people who were treated, it's been shown not to work, of course, but they also have neurological defects and deterioration up. And the ones I've had with these defects have done terribly. So here we see another couple of things. So you can get hyperpigmentation and decreases in the hand, pigmentation, creaks in the nails, and in the mucous membranes, and this is Addison who first described it. So steroid replacement, we invariably and pretty much universally use hydrocortisone. So children are different to adults, and the main thing is that children are growing. So with the hydrocortisone, we use 8 to 12 milligrams per metre squared per day. We give it TDS with half the dose in the morning and a quarter of the dose at midday and in the evening. And we adjust the dose based on symptoms, which is a predominant way of adrenal insufficiency, and with ACTH, 1708 PDHE, testosterone, depending on whether you're an adrenal insufficiency or whether you're CAH. The fludrocortisone, 25 to 100 micrograms twice a day, and we adjust that based on plasma renin and blood sugar and blood pressure. In neonates, we need relatively high doses. We're often giving salt, or in the older kids we're just letting them have free access to the salt. But in the neonates, what we do is we give them what ends up being relatively high doses of fludrocortisone and offer salty water 2 to 3 times a day. But the doses they need are often as big, if not bigger, than adults in the real salt wasters to control their salt waste. And that seems to be just a difficulty with the kidneys to respond at that age. I've never heard a good explanation for why that's the case. Now, we have a lot of kids that we like weight CAH. And what we usually find is that if we just treat them with hydrocortisone, then their 75 and their androgen remain high, or else you really have to get up around the 18 milligrams per metre squared per day to actually get suppressing their growth. And so with those people, you can often give them a small of the fludrocortisone, and you'll actually control that, control the androgens. even though they're not supposed to be salt wasting, they appear to actually do have some salt wasting, which if you don't do something about it will mean that they'll have high androgens, you'll have to have high steroids, and you'll have to lose height. So most children at our centre, very few of them are on more than 12 milligrams per metre squared per day of the hydrocortisone, and the vast majority I have always made it to normal final adult predicted final height. So in the maintenance phase of things, hydrocortisone, we never or rarely use prednisone and dexamethasone or betamethasone. And the reason for that steroids dramatically impact them. And every time we've seen it used, those have ended up small. And the reason for that is that you've got small children. It's hard to do fine adjustments and to get it exactly right. And there isn't, it's a bit like the estrogen activators, inhibitors, where you can have different effects based on the type of inhibitor. This is the same, where it has more of an effect on the bones than the other, than dexamethasone. So stress dosing, this is an interesting thing because we've come up with some new ideas recently on this, which we haven't published yet, but I'll share them with you. So we use double dose in people when there's a stressful event, such as a viral illness, a usually excessively active day, such as they're running or what have you, they're travelling or they're unusually tired. And we triple the dose if they have fever, abdominal pain, nausea, diarrhea, injury, travel, or sometimes immunisation. And then once they're over the stress, we'll keep it double until they're well again. But when we say double dose and when we say triple dose, what we actually mean is double the biggest dose of the day, all day. So if this person was on 6, 3, 3, for a double dose we'd go 12, 12, 12. For triple dose we'd go 18, 18, 18. For that is that if you have a stress response, it's the same at the middle of the night as it is at 8 o'clock in the morning, as it is at any time of the day. And if you just use the double of this one, double of that, then you won't get enough hospital for an adrenal crisis. So we've actually significantly and dramatically decreased our rate of presentation to hospital. Started doing this. The other things we tell people is if in between they feel unwell or they feel sick, they need to have another double dose or triple dose until they, and they can do that as often as they need to until they're feeling better. We use iron hydrocortisone if they're vomiting, if they've got severe injury or loss of consciousness, and that's usually 1 to 4 milligrams per kilogram. I do use oral dexamethasone. I've got some people who literally 800 kilometres from, so live in the middle of Australia with no one within a 600 kilometre radius. And what that means is an adrenal crisis take 24 hours to actually get them. And so what we do with them is if they've got nausea, temperature, abdominal pain, diarrhea, we give them the oral hydrocortisone, or if they've had IM hydrocortisone, we get them to then have a dose of dexamethasone. And dexamethasone, 0.1 milligram per kilogram, is equivalent to 2 milligrams per kilogram every 4 hours for 24 hours. So it's very effective, and the people I've used that in, it's been very good at keeping them away and keeping them out of hospital. So adrenal crisis, IV hydrocortisone, I use 1 milligram per kilogram per dose, Q4 hourly. There's places which played up to 4 milligrams per kilogram per dose. The way I came up with 1 milligram per kilogram per dose is I actually did the cortisol levels before we gave the cortisone, and then 1 hour, 4 hours, and 6 hours. And what we found at 1 milligram per kilogram, it very much followed that pattern I was talking about, with the thing, by the time they actually got to 6 hours, they were down to what you'd consider to be a severe stress response in someone in ICU. And so we've never had any problems with this dose, and everyone's always gone well, whether you use 4 hours or 6 hours. And my take on it is if you're there and you've given 1 milligram per kilogram and they've got symptoms such as fever or nausea or something, it's because they've got gastroenteritis or they've got an infection or something, and you treat those specifically. IV fluids, bolus 10 to 20 milligrams per kilogram, maintenance, 5 maintenance, so fluid volumes of maintenance plus 5% dehydrated, using normal saline of 5% dextrose, and you continue the oral hot food with cortisone. Monitoring heart rate, blood pressure, temperature, fluid balance, glucose, blood gases, UECs, and treat the underlying cause. And remember, one of the most common is in diabetes. Non-adherence is one of the most common causes. Provision of medications is extremely important. So, in conclusion, adrenal insufficiency is common. Function tests are reliable and require to really understand them, and it helps to understand the central adrenal help. A steroid replacement needs to be monitored closely to development, and stress replacement plans need to be very clear that families can follow them, and absent crises need to be This is some of my research team from John Hunter Children's Hospital. This is the Hunter Medical Research Institute. Someone asked about Laureate Professor Graham Goodwin. He's an books, and he actually uses some of his academic prizes to prop up his chair. They're falling off the walls. They're everywhere. A very, very smart guy, and the rest of my team is extremely dedicated, and I thank them heartily for their efforts. Thank you.
Oh. Okay. And we're getting to come next year.
I took too long.
So we're going to take them for some shopping and something. So, yeah, please, you are alone.
I have to ask. Okay, no problem. I am audible. I need it. And they can understand my accent. So there is no problem. Anyway, so, okay. So, when people are on exogenous, everything you said was perfectly clear. Thank you. I understood it. And I even understood why physiologically we have to cripple it the whole day when we are doing it. I was doing it, but I didn't correlate till I heard your thought. That's okay. Thank you for that. But my question is, suppose somebody is on exogenous steroids for some dermatological conditions or rheumatological or pulmonary conditions, and they have abused it. Now they have exogenous steroids and they have weight gain. So how do you assist them in that?
So first of all, you get it from history. So the family will tell you, and the thing about it is the people who become have impaired adrenal function from that. The parents are very particular people. You'll find that they're very caring and they love their parents and they're very exact. And so teachers are a big risk factor because they'll do it. And so they're the people who give exactly what you say. The other people who get there and give it occasionally and aren't compliant, it never happens with them. And so first of all is the history, and the parents will give you a very clear history and they'll tell you exactly what is happening. And often the reason they've come to your attention is because something will have happened. So they'll have come into a hospital, they'll have missed, and they'll have had an illness and they'll have an adrenal crisis, and people will pick it up and you'll be asked to see them, in which case they've had an adrenal crisis. You've got the history of the adrenal abuse, of the steroid abuse, and so you don't have to test them. What you have to do is withdraw them from them. And so if they've been relatively well, what we do is we give them stress doses and tell them how to do the stress doses and don't give them anything in between. But if they've come off it, then they just on a dive, then what we'll do is often put them on maintenance hydrocortisone and then wean it off at a stepwise. So I usually bring it down over about 2 to 3 weeks, and then leave them with stress doses to have. So they still have stress doses available for till, but not on anything usually, and it takes 6 months before you can say, no, you don't need this anymore.
If the maintenance dose, if they are in crisis, the full dose. Otherwise, they are in maintenance dose, taper every 2 and then.
Oh, no. You taper them over. You don't take a long time to taper it down. So usually what you'll find is that, so if they've come off and they've immediately gone down, so they've missed a dose for a few days and they've had adrenal crisis, then you'll have to put them on the maintenance. You wind that down over 2 to 3 weeks. It doesn't take a long time, you just wind it down. But they're still at risk of adrenal crisis for about 6 months after. But unless you get rid of the steroids, then you'll forever have this risk. So you've got to get rid of the steroids. So you wean it down over a couple of weeks so you can get them off the steroids, but then you give them the stress. Yeah.
Just the viral and the fever and the things.
Yeah, and yeah. 6 months. And usually after the 6 months, that's it.
Don't do any test to show that they are fine.
Because if they've gone for 6 months without needing it,
They're fine.
yes.
We go to the last presentation before they move out a little bit for shopping.
So no camps, no transition.
We'll invite you.
I've mentioned the camps anyway, so that's fine. Thank you. Here. Oh, I've got such a loud voice. You doing my slides for me? Oh, thank you. Yeah. As I said earlier, my passion is children with diabetes in schools. And I've been doing school visits for about 20-something years, and I've learned a lot from parents and teachers and my health professional colleagues on the way. I've got Life for a Child logo up there, but actually I don't really do any school visits, obviously, because I don't travel to, India or Africa. But when I do travel to the countries, I always do this talk because school is a problem for children with type 1 diabetes all over the world, and there's so much controversy about it. And my passion before I die would be to see standardization all over the world. Diabetes. I know it sounds incredibly idealistic, but I'm sure it can be done. I really am. It can be done because it's not that difficult, I don't think. Thank you. First of all, I'd like to know and I'm not telling you what to do, but I need to know what happens in your schools. What do you do? School visits? Do the parents talk to the teachers? Does nobody talk to the teachers? How does it work?
Definitely go to the teachers, and we always teach them to tell their teachers in every class. I can see there's a change in scenario. Earlier, in any school there would be one child. Nowadays, there are
More.
children. And type 1 diabetes, 3 children in the whole school.
Right. Okay.
So one is in class, second one is higher.
Yeah.
And what schools think is depending upon their previous experience. Like if they have a good experience about the children, they welcome that. If they have not so good experience, they push them back. It is
Yeah.
actually mixed experience. Last year, 2 good things have happened in last 2 years. In our center for secondary education, there is board exams of 10th and 12th. And now type 1 diabetes children are allowed to have snacks which include fruits. Earlier it was not there. Actually speaking, when I was in 10th, no one said me no. When I was in college, my teachers allowed me to have food. I don't know why, but I was allowed. So, but many didn't say so. Many is 80 to 70. And now, last month, NEET exam also has allowed candidates to eat during their examination. Candidates is like
Type of children you saw in the free clinic.
Yeah.
In government schools, nothing exists. We
No.
have to be honest.
Mm.
Teachers wouldn't be taught.
No.
There's no, the poorer and the government schools, nothing exists.
No. Well, in Australia, it varies, and there are some. It's too loud, isn't it? Is it? In some schools, the teachers are really good, and in my experience, that if the principal is on side, it filters down to the rest of the teachers. But I heard of a child the other day who was 6. And the teacher's aide actually came to me at an event. Somebody had told her I was a diabetes educator. And she came to me and she was in an absolute panic because a union representative had gone to the school because she'd heard that this teacher's aide, who was not a teacher but helping in the class, was helping the child to manage his pump and do his blood glucose levels. And it was all working beautifully, perfectly well. And then this union representative had obviously been told by an insider that this was happening. And she made a visit to the school and caused a big fuss and scared the principal witless. And he stopped everything and told the teacher's aide that she couldn't help. And the teacher's aide said, well, I'm sorry, but I have to, this is working perfectly well. I'm happy to do it, etc., etc. Parents were happy, all the rest of it. And the day after I saw this teacher's aide in the panic, she asked me for advice about what to say in the meeting. Parent wasn't going to be at the meeting. Teacher's aide, union rep, and the principal. So that poor teacher's aide had 2 people against her. And I haven't heard since what's happened because she's got my phone number, but she hasn't phoned me. So that's the sort of thing that is happening in Australia, and I know it's happening all over the world. And it's
That kind of thing happen in India because we don't have such strong laws that if someone is helping, they can say, please no. But we don't have nurses. It's an individual experience. Teachers, when they are interested, definitely help. I studied in what we call government school in their dialect, and 10th was very good. 11th, 12th was not so good, but that was not a big part of my life. Went away. When I hear other children, the most problem that is sometimes teachers think that the child is blind. Sometimes they don't allow them to go for urination.
Yeah,
Like
yeah.
simple things like
Yeah,
going for
yeah.
urination.
We have that too.
Once they had Bangalore also, I visited around 4 or 5. There was one child, and teachers were very much concerned, but they knew nothing about diabetes management. People were 450. Another school was not a government school. This was convent school. Called convent schools in the mid of the Bangalore. The other was a different kind of school, but in that the teachers were understanding. Actually, they had some previous children, so they have assigned the duty to that senior student to look after the junior student, although they were not related. But the things were going on fine. There were third schools where the teachers had written a letter and the doctor has himself written in 50 centers in Bangalore. Doctor had given his personal guarantee that nothing would happen to my child and you should let him study. So these are very on and off cases where they get treatment based upon the teacher's bias.
Yeah, yeah. And that's very similar. That those are the stories I hear all over wherever I go. Thank you. Thanks for giving me an idea of what happens, because I don't want to stand up here and say all the wrong things. We missed one. Oh, okay. Preparation is the key, and visit the school sooner rather than later. Now, whether that's the parent doing it. Now, in Australia, some parents are very eloquent and they're not aggressive, and they can go and visit a school and talk to the teachers perfectly easily, and everything's fine. But some parents do, they're anxious, obviously, and I don't criticize them for that, but they go in and they say, you will do this, 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 and this for my child, and if you don't, you know, you're for it. And that sets up problems. And that's where, when I used to do mediation visits, it was always that sort of scenario where a parent had upset the teachers. And let me say from the beginning, I have sympathy for the parents, the child, and the teachers. Teachers nowadays have to be experts on asthma, anaphylaxis, epilepsy, plus they've got to teach and prepare all their lessons. And they get, you know, they get tired. I know they have long school holidays and everything, but, you know, it's a big responsibility. And the whole thing is education is the key, as we all know. So we need to explain diabetes simply and don't give too much information. Resources and pictures are, is my DVD gone? My Professor Bumblebee DVD. Somebody's got it. We produced a few years ago, and it's old now. It's 2004 we produced it, which is 14 years old. But I think it's still, would you agree, Bruce? It's still pretty relevant. It's a 12-minute DVD, and I brought an English copy, and it should be somewhere around. It's called Professor Bumblebee's Guide to Type 1 Diabetes. And it's 12 minutes, and it's very visual. It's a cartoon, and it explains very, very simply what happens to a child's body when they get type 1 diabetes. And it's a very good resource to take to a school to show teachers exactly what happens. It's very simple, and you know, some people say, oh, it's only a video and it's for children. But actually, a lot of parents have said to me, I didn't actually understand diabetes until I saw that video. And it's on YouTube, but I bought one copy. So resources and pictures and visual things are really good for teachers. And discuss what the other children are told. I told that story earlier on about me talking to the other children. It's important that the other children see what the child with diabetes has to do. I'm very much against children with diabetes being sent over to the office to do their blood glucose. They need to do it in the class, not disrupt everybody, but away from everybody. The only time it's worked against the school was when the teacher was with the child and then she was doing the blood glucose, and all the other children went, test me, test me. And she went round the whole class with the same blood glucose lancet and tested every child. So you can imagine what was on the front page of the newspaper the next day. There was a big kerfuffle. I think everything was all right, but it was a nasty moment. There's some of these, this has gone too far because I've missed half of. Next, can I just go through? Must have taken it out. Anyway, yeah, I did. Okay. So hypos, I mean, we used to, 20 years ago, we always used to say, don't worry about high levels, just worry about lows. That's all changed, obviously. And with children on pumps, because they've only got basal insulin in their pumps, there's obviously a greater risk for DKA. And when they're doing activities and playing in the playground, their pump can come, you know, loose and come disconnected. And so you've got to be careful about high levels. So I don't know what you said. Do your children take a hypo kit to school, or just?
They carry it in their bag. The mother give one super in a
Yeah. And your parents, our parents are expected to top up that hypo kit. The thing that makes me cross with hypo kits is the child should be able to carry it with them all the time. I mean, it's very simple. I went to a preschool once where there was a 3-year-old with type 1 diabetes, and I did the visit and talked to the teachers, and I said, you know, where do you keep the hypo kit? And it was in a cupboard up here, which nobody knew where the key was, and it was locked up. And so, no, you know, if they wanted to get to it quickly, it was absolutely ridiculous. So we moved that. So, oh, sorry, Tanzania, that was my last place I visited, and I forgot to change it to India. So the parent should keep it replenished, and it should be handy, and they should be allowed to treat it promptly. Now, I heard about a boy in Africa recently who he's 17, and he had a hypo, and the teacher made him do push-ups in front of everybody because he thought he was, being stupid and pulling a fast one. So teachers, have to listen, and this is all part of the education. Also retreatment if necessary, and sit the child down and stay with them. And that's another reason why I don't like them going to the office to test, because they've got to walk to the office, and if they're having a hypo, they're going lower. They've also probably got a buddy with them, and it's too much responsibility. Then they might have to wait for the office lady to help them, so they should be treated on the spot. And when I do a school visit, every teacher should be there. There's no point in talking to two teachers and the principal, or one teacher or the office lady who's the first aid person. You've got to talk to all the teachers because they all come into contact with this child. I think that's very important. And we don't have school nurses, only in the private schools. And even they are terrified to deal with children with type 1 diabetes half the time because they don't have the education. Thank you.
Most of the time, practically, where many schools have parents' numbers, the first thing is they give a call rather than meeting in
Yeah,
their own home.
that's right. Yes, yeah. So if you do the school visit, and I know school visits by an educator are very time consuming, and they're not that cost effective because it's taking you away from your clinical work. But there's nothing like a face-to-face talk from somebody who knows what they're talking about to teachers, because teachers are a bit like doctors and nurses. They sometimes don't like being taught or talked at. And I mean that in the nicest possible way. But I had a teacher once. I walked in with my PowerPoint, and I put my USB in the computer, and she came past and she said, "I know all this. I've heard this before. My mother's got type 2 diabetes." And I said, "Well, maybe just sit down and wait and listen." And she came and apologized to me afterwards because she said, "I'm sorry, I had no idea." So people, you can't blame people. They don't know. So you have to let them know. So it's got to be a three-way, or four-way when you're talking about the child as well. Talking, parents, health professional, team, and child and the teachers. Discussing options and for management at school, and the parent or the educator really needs to go every year as the child moves class, because people don't pass things on. And we used to run diabetes seminars, didn't we, Bruce, 20 years ago? And you'd get two teachers coming from 3 schools, free, and they would listen, and it was fine, but half of the time you knew they wouldn't go back and tell the other teachers. And now I hear that they're resurrecting those diabetes seminars in Australia, and it's something that we found didn't work 20 years ago. So, it's very frustrating that things don't get passed on. That's my only negative comment. So you have to adapt for the age of the child, obviously. I mean, an older child should be able to look after themselves, but often when they go to senior school or high school, it can actually be as hard as starting primary school, because they're going to different classes, and they're very much on their own, and they don't get much support. So the high schools, I found a lot of the time were the most resistant to listening to an educator going and talking to them. So, and it's a fine line about talking and telling you what to do, or just discussing it and letting them ask questions. And that's why I think face-to-face school visits are really important, because the teachers can ask questions and feel they can ask questions. But the way things are going now is e-learning modules, which I'll talk about in a minute. So as I said this morning, all ages have different needs. And when kids go to high school, they may be allowed to carry their stuff in their bag, but sometimes they have to take it to the office. And that really upsets teenagers, because they don't want to have to go to the office and ask for everything all the time. And they need everything with them. So again, the only time I've had trouble with that was when another boy got hold of a pen, an insulin pen, from the one with diabetes. He took it out of the bag and started mucking about, and trying to stab people and all the rest of it. So anyway, somebody got it off him and everything was fine. Thank you. So, as I said, all staff should be aware of the child and aware of where the hypo kit is. There's no point in having it 3 miles away in the office. It's got to be with them. Testing in the class or the office, I've said what I think, and you know, some people disagree with me, but I think most people would agree that it's dangerous for children to go walking off and disappear and everyone forget about them. Storing equipment, that can be a problem in high school where the child isn't allowed to keep their insulin on them. But most schools, if you sell it in the right way, they will come to the party and realize that the child has got to have a little bit of responsibility. And it always amazes me that some teachers are a bit like some parents, that they deal with children every day of their lives, but they still think that a 9-year-old who's had diabetes for 5 years can manage their diabetes by themselves all the time. They can't. Why would you expect that? So I think once they realize, and once you sell it to them, you have to get them on side. That's another thing. I went to a school and the mother, I hadn't met the mother, I'd only spoken to her on the phone. And we were talking before I went in to do the visit. And she said, well, I want you to say this, 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 and this. And I said, well, it won't work if I do that. I need to do it how I need to do it. And she got quite annoyed with me. And, it was almost, why are you here? I can do this myself. Anyway, we did the school visit and I let her talk at the end. And it's important, I think it's important to have the parent there if they listen to you. And in the end, she realized that you don't have to beg and bow and scrape, but you do have to mediate and look as though you're compromising and sell it to them. Otherwise, the teachers are just offside straight away. It's like life. And the sports teachers and after-school care, I don't know whether you have after-school care, but we do, and before school care, it's very important that everybody knows how to treat a hypo and that the child needs to eat at a certain time, etc., etc. Excursions, that's another thing that can be a problem, because sometimes I used to get a phone call 2 days before they were going to camp. What do we do? And this wasn't a diabetes camp, this was a normal camp, but a camp for everybody. And you need to prepare way before that. And sometimes parents go to, do you have your camps and activity days for parents as well? No? No. Yeah, I think either way works. It's fine. I think sometimes it's good to have the parents. The camp I used to run, we had parents in one room and the kids were all in the other, and it worked. It worked quite well, but it depends what works for you. Special occasions, I think I mentioned this morning, sometimes teachers have sweets for treats, and it's probably not the best idea for any child, because they should be for treats. But it's a reward system, so it's probably better to have a different reward system. And they usually agree with that once you explain why. Thank you. So this is a little girl in Nepal with her friend. The little girl on the left is one with diabetes, and she's called Amita, and she's about 7, and she's doing quite well at school. In Australia, we do have special provisions for exams. That still happens, doesn't it, Bruce? Yeah. Where children and their parents can apply, I think it's about 12 months before, if not, it's 6 to 12 months anyway. So you've got to be prepared. And some children don't want to do it because they don't want to sit in another room. They don't want to look different. They don't want to test when they're doing their exam. But it's actually quite sensible to do it, just in case you have a hypo or you have a high level and you're foggy thinking and you can't do the exam. And then you're allowed to do the exam again. So that's quite helpful. And then they're allowed to have their meter with them. I put, would this occur locally? Probably nobody would say if they were doing an exam, would they here? Or if they were sitting an exam, would they have special provisions? Doesn't. No. I think that's quite good. Thank you. So with high blood glucose levels, they obviously need to be able to drink water, go to the toilet, test if necessary, test for ketones if you've got the equipment, no extreme exertion. Some children I know have had a high level and the parents told them to, the teachers to let the child run around the oval 25 times, you know, to get the blood glucose level down. Anyway, so you have to put that right, and then rest if they've got a headache or a tummy ache in sick bay, but don't leave them on their own, and obviously call the parents if you're worried. But a lot of teachers, I think you said earlier, you know, they're on the phone the whole time to the teacher panicking. So that's when I think the education and the school visit is very useful, because it calms them down a bit. So then the school should have contact details of the parent and a backup. And in Australia, we usually, in staff rooms, they have a picture of the child and a management plan. And it's got to be a simple management plan, though, not, you know, reams and reams of paper, which nobody will ever go through. And it should be updated as necessary by the parent and the health professional diabetes team together. So it must be updated regularly, and all the teachers should know which child has type 1 diabetes. I went to a school once and they made the one child with diabetes wear a red cap and everybody else was wearing a blue cap. Poor child. So I said, well, sorry, you just got to memorize his face. You can't do that. You know, that just makes him feel more different. Adolescents need privacy. I mean, they usually go in the toilets to do their injections or whatever. What happens with an injection at school here? Do they have an injection at school? They probably don't. They do? They do? They're allowed? What about the little ones? Who does that? Does the parent? Yeah, yeah. We try and avoid parents going in. A, because if they work, they're missing work. B, the child stands out like a sore thumb if their mother's coming into the school every day to do their injection. It really is not a good start. And that's when we teach the office staff or who, you know, a teacher to do an injection. Now, a lot of my colleagues in Australia are very against this and they say it's dangerous. But in about 20 years of doing school visits, I never had one problem because I taught them properly. They always checked it with 2 people and I watched them do it. I'd watched them do the whole thing and I never had a problem. And as I was leaving my previous role, I wrote some modules and we were getting them passed by the Department of Education. But unfortunately, my successor didn't carry that on. And now, as I said earlier, it's gone back 20 years. So it makes me very, very sad and very distressed. So yes, they may omit the injection because they don't want to stand out like a sore thumb. So that is a classic time for a child to miss an injection or a bolus with a pump if they're on a pump. And they may ignore hypos because they don't want anybody to see. So, and a lot of them may run themselves high because they, as Bruce said, because they don't want anyone to see them having a hypo. And they usually don't test very much at school, but some do, but some don't. And you know, the meters are much tinier now. I mean, when I was training in the Middle Ages, they were this big, like the pump. So now everything's a little bit more discreet. The thing that upsets me, I was saying to somebody this morning, I can't remember who it was, the thing that upsets me is Life for a Child can't supply pens to children because syringes and needles, you know, there's that connotation of drugs, and they're just, pens are just much easier, and you can just say it's a biro and nobody worries. So I wish we could, but we can't afford it. So this is what I used to cover in my school visits. I won't go through it, but if there's glucagon, fine. But if there isn't, obviously you have to go through what you do if they're unconscious. You know, turn them on their side, coma position, and call an ambulance. And sport, special occasions, exams, and high blood glucose levels. So very simple. I could do it in half an hour, and then have 10 minutes for questions, and I'd go out for either first thing in the morning or last thing in the afternoon. And I had a very good relationship with all the children's hospitals within our state in Australia, Bruce's being one of them. So if ever I was doing a school visit for a child, I'd always ring up the school first, the hospital first, and say, is there anything special about this child? Because I don't know the child half the time. The parent would ring me school would ring me, but I needed to know anything special. So I'd do a very broad school visit, but then they would contact their health professional if they needed help. So that's really important. You can't go into, say, a seminar and talk to these teachers and have a parent there and say something about, what did you say this morning? Something about a hypo will kill you. This has happened, hasn't it, in Australia, that the educator who was doing the seminars had not spoken to the health professional that was looking after the child, and unfortunately the health professional couldn't be at the seminar, so wasn't there, and this educator doing the session said that. You can imagine the panic. Well, then there was, problems, and it took six weeks, I think you told me, Bruce, to sort that out. Now that was totally unnecessary. So you have to have communication between all parties. It's absolutely vital, and if you don't do that, I think you're lost, quite honestly. But it needn't be like that. It really needn't. Thank you. So the parent needs to continue dialogue with the school, and obviously the health professional looking after the child, it's usually the educator, even the teacher at the change of school year, and as they start, go from preschool or childcare to kindy up to high school, and then university, but then usually the student can do it themselves. And negotiate on both sides. Don't try and go in and tell them what to do. That's when problems arise, and compromise on both sides. Thank you. Just some resources. Now, the IDF Kids Pack, do you know about that? Because that was trialed in India, yeah, and Brazil. And I was on the advisory committee for that. So it's in Hindi, you knew that, I hope. And it's in a number of other languages too. And we've just added a nutrition component, and one of your dietitians was here this morning and is involved with it. So that's a very good pack. It wasn't exactly how I thought it should go, but it's better than nothing, and it can be adapted by less resource countries, except a lot of the time they don't have the money to do it. So that's the website. Thank you. And the e-learning modules. This is the Australian Paediatric Society, of which Bruce is a member in Australia, and a paediatrician with a special interest in diabetes has been instrumental in doing these e-learning modules, and the teachers absolutely love them and find them really, really useful. They've been endorsed by ISPAD, but unfortunately, some centres in Australia are not happy about using them. So this is why we need to get this standardization, and that's what I'm talking about at ISPAD. And I said this morning, and I'll say it again, these children are just the same as other children. We just have to remember their diabetes. Thank you for listening. Thank you. Thanks. Just remember I have some slides.
Now, I request conclude with the prayer.
First of all, I'd like to thank you, both of you, for a very nice, very informative session. And thank you, sir, to treat us like a family, to treat us like a child, which makes us feel full of love. One thing which I say about the center is when nothing works, love works, and we have here one thing which is abundant is love. And that makes the things work in any situation. I have to say a prayer. I'll say a prayer which my father used to teach me. Astoma Sadadamaya, Tansoma Jyotirmaya Damaya. I forgot.